Hello and welcome to today's episode of Not Defined by Endo. Navigating an endometriosis diagnosis can be very tough and confusing, and many of us have struggled to get access to excision specialists or professionals that truly understand the disease. So today, I'm bringing an excision specialist to us. We'll be talking today with Dr. Shaheen Khazali about how to navigate an endometriosis diagnosis, stages of endo, excision surgery, and even the process from diagnosis to referral, specifically in the UK. Remember that I am not a healthcare professional, so whatever I share on this podcast is to inspire and empower you to take control of your health and your bodies. Please always speak to your healthcare professional before making any major changes to your diet or lifestyle. With that said, let's get right to it. So thank you very much for coming on the show.
Thank you for having me.
It would be really good to probably introduce yourself just so that the audience can know who you are.
Well, I am a consultant gynecologist and an endometriosis surgeon. I am based in the UK. I work at the Center for Endometriosis and Minimally Invasive Gynecology. My NHS base is at St. Peter's Hospital, which is in Surrey, Chertsey, just west of London. And my private practice is in London, Lister Hospital in Chelsea, and also in Surrey. My practice is mostly focused on severe endometriosis, particularly surgery for patients who suffer from advanced disease and need joint operating with other specialties like colorectal surgeons and urologists.
I've actually spoken to quite a few other professionals, but you're the first person in the UK that I'm speaking to. So I'm really excited because I somehow have not been able to get to people in the UK. And since I'm based in the UK, it's really exciting because I feel like I want people that have my experience in the UK to understand, what it is to have endometriosis in the UK and how to navigate the system here. So really excited. And I know that everyone in other parts of the world will also learn from this. So let's get right to it.
Okay, it's my pleasure.
Yeah. So the first thing I'd like to ask is, what do you do if you suspect that you might have endometriosis? So probably from your symptoms or from how you're feeling, what's the next step?
Okay, so perhaps it makes sense to talk a little bit about what endometriosis is and what symptoms it causes, which then takes us to why it's challenging to diagnose. So endometriosis is a very common condition, as I'm sure you've covered in your previous podcasts. It's a very common condition, affects around 1 in 10 women in reproductive age, and it causes painful periods, pain in general, fatigue, difficulty with conceiving, fertility issues, pain during sex, pain when opening bowels. But the problem is a lot of these symptoms are common, and not only endometriosis patients suffer from these. So for example, fatigue is a good example. You can be fatigued for a number of different reasons. You may have painful periods, but it doesn't necessarily mean that you have endometriosis. So it also, it then raises the question of, so how do I suspect I have endometriosis? Should you go to your doctor if your periods are painful and ask to be referred for endometriosis assessment? Should you worry about having endometriosis if after a few months of trying you're not falling pregnant? And the answer is no. It all comes down to what's normal and what's not normal. Let's forget about endometriosis for a second. It's not normal to be in such pain that affects your quality of life and your day-to-day activities. So it may be okay or common, let's say, to have the sort of period pain that responds easily to a couple of paracetamols and you can get on with your life. But it's not okay if you're missing school, if you're missing university, if it's affecting your job. So first is to recognize what's not normal. So this is one example. This is not normal. It's not normal to have so much pain during intercourse that you don't enjoy it and you try and avoid it and it affects your relationship. That's not normal. So if any of those are happening to you, then it's time to go and seek help and it's time to go and talk to your doctor. Is it going to be endometriosis? Maybe, maybe not, but at least somebody needs to look into it and make sure that you're receiving the care that you need.
So how would you say one should go about finding a specialist? So say I have all those symptoms that you've mentioned earlier. Do I just go straight to my GP or should I ask specifically for a specialist? How should I go about that?
Well, it's different in different countries. In the UK, we have a referral system and almost everything starts from the GP, particularly if you want your care to be done under the NHS, you always need to go to your GP and get a referral. In the UK, there's also another rule, and that is that patient can choose where to go and who to go to.
Okay.
And there is a general rule, and that's not specific to the UK, that the first step in you getting better is to see someone that you trust and you believe in. So more and more people are doing more research into who they want to see. And different people have different criteria. Younger generation now is used to the TripAdvisor kind of system, the Amazon kind of system. So you go and look at what other people say about the doctor, what the others have experienced about each particular person. But you need to be careful about that because sometimes, and it applies to TripAdvisor and Amazon as well, you may look at a particular hotel and it may be an excellent hotel, but for whatever reason somebody didn't have a good experience in that hotel and they left a bad review. But it ultimately, the more people leave a review and talk about a hotel in this example, the more reliable the information will become. Now, when it comes to endometriosis, we are in a way quite lucky in the UK because we are one of the first countries in the world that started the centralization of endometriosis service. That means that there are hospitals, there are clinicians that are putting themselves forward and getting accreditation for looking after women with severe endometriosis in particular. And that is done through the British Society of Gynaecological. So their website is bsge.org.uk. And by the way, I should say a disclaimer here that I'm the honorary secretary of the BSG. But this interview and the podcast is my personal opinions and advice, not the views of the British Society of Gynaecological. So that's important as a disclaimer. So yes, as I was saying, there are centers that have the criteria to become endometriosis center, and they submit their data on a yearly basis of how their patients are doing, how many operations they've done, what kind of operation they've done. They need to have a dedicated endometriosis clinic. They need to have a specialist nurse. They need to have colorectal surgeon, urologist working with them. So that would be, in my opinion, the first step.
Okay, so this means that for people in the UK, it's possible for you to actually go to the BSG and find a specialist that you're interested
Yes.
in and reach out to them directly.
Yes, but that's if you need to be treated in a BSG and
Okay.
endometriosis center. So let me expand on that a little bit. So um, uh, we think something around 1.5 million women in the UK suffer from endometriosis.
Okay.
There are only 50 endometriosis centers in the country. Those 50 centers are not going to be able to look after all of those
Yeah.
women. And they don't actually need to look after all those women because most of that 1.5 million women either won't need surgery, or if they do need surgery, it's not going to be very complex surgery.
Yeah.
So it will be something that a general gynecologist should be able to deal with. Having said that, for someone who doesn't know what kind of severity of endometriosis they have, there is still a choice. They may choose to go to an endometriosis center and see someone who specializes in the field. But most GPs, because they need to make sure that they don't inundate the endometriosis services with all the endometriosis patients, may choose to send you to your local hospital to be assessed, and a general gynecologist may see you. They may not have a particular interest in endometriosis, but they are a gynecologist and they're trained, and they may assess you and then decide if you need treatment in a more advanced level, then to refer you to an endometriosis center.
Okay, I see. Interesting. So talking about surgery, you mentioned earlier that you may or may not need surgery. So say you need surgery, what kind of questions should you ask your doctor before a laparoscopic surgery? What's important before surgery?
Yes. So the answer to that is also very general. It shouldn't only apply to endometriosis surgeons. You know, if you want to have any kind of procedure, the first question is that person expert in that field? Now, this is where things become a little bit confusing, because when the surgery is not particularly complex, then everybody is trained to a level that can do it. With endometriosis, the issue is that we have one name for the disease, but it comes in multiple different severities and complexities. The NICE guidelines have at least attempted to give some guidance on how to categorize different complexities, and then recommended that certain categories are treated in an endometriosis center and some are treated in the gynecology center. But you're sitting in front of a doctor, say a gynecologist, who is suggesting, or you've agreed that surgery is the next best step. And my advice would be to be very frank and upfront about your real questions and concerns. For some patients, it's less important than the others, but some women, and I see that more and more, that they are very direct in asking, so how many of this type of surgery have you done? What is your complication rate? Do you consider yourself someone who has an interest in this field? And then you can directly ask, do you think it would be better if you sent me to someone who is an expert in this particular field? Now, I would say all doctors, maybe there will be some exceptions, all doctors will naturally act within their competence and expertise for various reasons. It just makes a lot more sense. We're all out there to help our patients. And for example, I have been trained and I have experience in performing surgeries for urinary incontinence. So I've done quite a few of those when I was training, but I don't accept any patients with urinary incontinence. I don't operate on those patients. Why? because I probably do one or two, if that, of these procedures a year. It's not a particularly difficult procedure,
Mm.
but I don't do it because I think it would be much better if somebody who does this operation every day
Yeah.
does this.
Yeah.
And at least in our hospital, all my other colleagues think the same way. So if they have a patient with endometriosis, they refer it to our team. If I have a patient with, say, urinary incontinence, I refer it to them,
Mhm.
because I think the patients will be much better looked after that way.
Okay, that's great. So I have a question. This one is a bit what's the word, it's usually it's in the circles of endometriosis patients and advocates. We talk a lot about the difference between ablation and excision surgery. So like you said just now, that you obviously most doctors work within their competence, but there's a lot of online publications and everything about the difference between ablation and excision, and how ablation is burning off the endometriosis, and excision is basically cutting it out from the roots. And the advice and the thought is that everyone should ask for an excision surgery. So what are your
Mm,
thoughts on this? And if, like, how should we patients approach doctors in asking about
mm.
the difference, and which one they'll be choosing, or which one they'll be doing for them?
Okay, so again, I'll give you a little bit of background to this. In medicine, we do evidence-based practice. What
Okay.
that means is that we look at the available research and data, the best available research and data, and then we look at the patient's expectation, and we put these two together with the doctor's experience and expertise, and the three factors will then decide what's the best thing to do.
Okay.
Now, to me, excision makes a lot of sense. And to me, it does not make sense to ablate the disease.
Mm-hmm.
And the reason I repeat the word to me is that the highest level of evidence, the research
Mm.
in the highest level, which is randomized controlled trials, have not really come up with an answer to this particular question. And I will touch on that a little bit more. But I always perform excision, meaning remove the disease,
Yeah.
because we know that endometriosis is very frequently much deeper
Mm.
than what we can see. And when we ablate the disease, which is either by applying heat to it or lasering it, we are only treating the superficial layer of the problem, and the rest will stay behind. And it just makes a lot of sense to remove the abnormality instead of just touching the tip of it and then saying, oh, there's no cure for endometriosis. And if the patient isn't getting better, that's because it's the nature of endometriosis.
Mm.
But the reason that I say this is a lower level evidence is that when they did randomized controlled trials on this, they haven't been able to show this difference with certainty. Now, just to confuse you even more, evidence and research come in different levels and different importance, if you like.
Okay.
When it comes to surgery, sometimes it's very difficult to run proper randomized controlled trials, because imagine if I want to compare excision with ablation, I need to recruit a lot of women
Mm.
into the study to then account for the differences in the surgical ability of the person doing it,
Yeah.
to the equipment used, to the completeness of excision, to the severity of the disease, and so on and so forth. Therefore, when I do evidence-based medicine, and I see what my patients want, what my experience is, which certainly is that excision does a lot better
Mm.
than ablation. And then I put it together with the available evidence, which, by the way, does suggest that excision is better than ablation, but only not in randomized controlled trials. Then I am convinced that excision is the right thing to do.
Yeah, I see. Okay, that's interesting. Thanks for that. So, you mentioned earlier about the different stages of endometriosis, or in publications and NIST guidelines. So, would you say that in your practice, recognize the stages of endometriosis, and what are those stages if you do use them?
Well, this is an interest of mine. In fact,
Mm.
I have developed a new endometriosis staging system called Venus, which is Visual Numeric Endometriosis Scoring System. And the reason I came up with this system was exactly the fact that there is no good staging system around. There are some that are in use but have their own problems, and I will quickly take you through some of them. So by far the most used, commonly used staging system is the ASRM system, or revised ASRM system, which is the American system that came out, I think, in the early 80s.
Right.
Now, when that came out, we didn't even know what deep infiltrative endometriosis is. So that staging system looks mostly at adhesions and then superficial type endometriosis, and doesn't even consider the disease that may be affecting the ureters or the bowel in particular. So that staging system has 4 stages, 1, 2, 3, and 4.
Okay.
And in my opinion, it's almost useless when it comes to endometriosis that we know this day and age. Endometriosis of stage 4 can be something that may take half an hour to deal with, or it may be something that will need 6 hours with a colorectal surgeon and urologist. And endometriosis stage 1 may mean anything that isn't particularly useful to know. But here we are. This is the most commonly used, and people still understand stage 1, 2, 3, 4. There are others. There is a much better system called the Enzian system, which is, in my opinion, a bit complicated, and it's not easy to navigate or to analyze the data, and it relies on the size of lesions, which, in my opinion, is not particularly useful for various reasons I don't want to go into. But the attempt that I've had at devising a new one is something that everybody, including the patient and the clinician, can understand, and it is more like a picture, like looking at the picture, knowing which side of your pelvis had what severity of disease.
Okay.
Now, just to add to all of this is another complication, which is endometriosis. The severity of endometriosis does not really correspond with the severity of symptoms. So you may have a very severe form of endometriosis, but not particularly symptomatic, or you may have only a little bit of disease and you may have excruciating pain. And that sort of has made things a lot more difficult, because staging, at least the attempt has been to come up with a staging that also corresponds with the symptoms. And I think that's where we've gone wrong. I don't think we can find a system that can both look at the symptoms and the surgical complexity of endometriosis.
Okay. Interesting. I'd like to know, do you have like a publication or something that I can share with the audience about your Venus system? I think it'll be interesting to have a look at it. Okay.
Yes. I think the easiest way is to just Google Venus, VNESS,
Okay.
and my name, Shaheen Khazali, and the publication will come up. So at the moment, I am working on a software, if you like, that you can enter as the surgeon, enter all the surgical data, and it would then create all the different commonly used endometriosis staging systems for both the patient and the next clinician to know. And that will take away some of the complexities of the issue.
Okay, that's great. I have another question about surgery. Should one expect, almost like always expect, a return of the disease, because we know there's no cure? So should we expect a return of the disease a few months or a few years after surgery? Or would you say recurrence would depend on, how the surgery was done and how effective the surgery was? Or is it something that surgery is almost like it's an effective treatment, but you're almost likely to have the disease come back? What would you say?
Mm. Well, first of all, I have a problem with the word cure when it comes to endometriosis. What does it mean, really? If you have come to me with pain and I operate on you and I take away every little endometriosis that is visible or not visible,
Yeah.
and even 5 years down the line, I go back in and there is no endometriosis, but you're still in pain, are you cured? No,
No.
because your problem was pain.
Yep.
And I'll give you another example. Say I operate on you, you're in pain, and I remove your endometriosis and your pain goes away. And in 5 years' time, your pain is still very well managed and
Yep.
maybe non-existent. But somehow somebody does a laparoscopy for another reason and they find some endometriosis somewhere. Is that a cure? So, what I consider as a cure is that I have managed to solve your problem. And that means I've cured you of that problem as long as it takes. Now, should one expect things to come back if you're talking about symptoms? No, not at all.
Okay.
Most of our patients, in fact, will get better enough to get their quality of life back. Some of them will tell us that their lives have changed completely and they continue to enjoy the effects of good treatment. But there will be some that will need further surgery or will need other intervention, and not necessarily because of their endometriosis. This is, remember, we are treating the person, not the disease. We're
Yeah.
looking at you as a person. We look at what problems you have and we try and address those. So answering your question, no, in most patients, appropriate treatment, which can include surgery, can lead to long-term relief from the symptoms.
Okay. That's good to know.
Mm-hmm.
What other, I would say, traditional and non-traditional approaches, so outside of surgery, to managing quality of life have you applied for your patients and have seen results from?
Yes. So it's very difficult in this field to um, pick the false claims and if you like, voodoo practices from the alternative medicine that actually works. The answer I always give to my patients is, if something works for you, then that's good. Okay.
Okay.
And I always say that my red line is homeopathy. That is one thing that I cannot digest at all.
Okay.
Um, some of these interventions and treatments, in fact, have some evidence behind them. Take acupuncture, for example. Acupuncture does work in relieving pelvic pain to a degree, but you need to keep having acupuncture, and that may prove costly.
Yeah.
Some other interventions like massage therapy and physiotherapy, these can work too, particularly physiotherapy. I wouldn't include that in the alternative medicine group. That is something that we actually use and it can be extremely helpful and effective, particularly in a subgroup of women. So the answer really is that every person is different. The things that I've seen most commonly work are nutrition, changes in diet and nutrition, and there's a big discussion around that in the community of endometriosis patients and outside. But I have seen a lot of my patients benefit from changing their diet, not necessarily because I think that makes their endometriosis better, but because in some patients there may be another problem going on at the same time as the endometriosis. And by removing some of the factors that may exacerbate the pain, you are going to help yourself anyway, and you're going to be healthier anyway, and therefore that can only do good.
Yeah, I think that reminds me of this I'll call it like it's like another condition. So SIBO, so small intestine bacterial overgrowth. There's been some articles and publications and all of that saying that there's a relationship between endometriosis and I think almost 100% of people that had endometriosis. I don't know how big the study was, had small intestine bacterial overgrowth. And I think that kind of had to do with the whole nutrition thing. And, people should also look into that if they have endometriosis. So, so I guess, Yeah,
that's another very important point that you're bringing up. The relationship between endometriosis and various conditions. Again, you need to be cautious when you interpret studies that have looked into that. Unless you base these conclusions on very large population-based studies, and I'm talking about millions of people in the study, you cannot really draw a conclusion because it's very easy to look at the data and analyze it in various different ways to get some relationship. We have a saying that if you torture data, data will confess. And I know
I like that.
Yes, and that's your area of expertise as well, isn't it?
Yeah. So I understand what you're saying.
Yeah.
It's true though. You can almost twist data in a way that you want to please your purpose.
Yes, and it's not the same as being manufacturing data or lying or changing things, but depending on the type of statistical analysis you use, what exactly you ask, and do you have a reason to ask that question, you may get answers that may not be particularly correct or helpful.
Yeah, very true. Okay, so I have a final question about endometriosis, and this one is about ascites. So many of us say, oh, I've got endobelly, I've got the blood, it's big now, it was small 2 minutes ago, and all of that. But I've recently seen that a lot of people are saying, oh, my tummy I always look like I'm 5 months pregnant. And some of us have been actually diagnosed with endometriosis related ascites. So how common would you say this is? And, how often have you come across this? And what would you say is the way to go in trying to treat that part of endometriosis? Because I know it's not everyone that has endometriosis that would have ascites, but, how common is the occurrence and what's the treatment?
Yes, so it's not common. It's in fact a rare presentation of endometriosis. I have had 4 patients with ascites in my whole career, and I am a particularly busy endometriosis surgeon. I treat a lot. I don't do anything else. Every day, all day, I'm dealing with endometriosis. So it's rare, but it's there and it happens, and it's very difficult to control and deal with. Sometimes surgery can help, to reduce the frequency of ascites occurring and appearing. Sometimes it's not easy, and you will end up giving medical treatment to a person for a long term. But a very important point to mention is that what you were describing about women's abdomen getting bigger, that's bloating. In 99% of the cases, that's not ascites. That the abdomen doesn't get better in those women because of ascites. It gets bigger for various different reasons, but one of them is that the muscle of the intestine will have a slower movement, and it becomes therefore not inflamed, but it becomes bigger, it becomes distended, and therefore the inside of the bowel is distended. Now, if you consider that you have around 6 meters of bowel inside you, even a little bit of distension in the lumen of the bowel can cause a very significant change in the size. And that's a very common symptom, again, of endometriosis, but not just endometriosis. Women with premenstrual tension, or even in normal women, you can see that usually in the second half of the cycle.
Okay, I see. Right. So do you have any last or final advice for patients suffering from endometriosis? Because I know you, like you said, you see them every day. You've seen all sorts, different types, different presentations. So what would you just advise, for people going through, this disease, regardless of what stage they're at, whether they're just finding out or they're already going through treatment, or, they're in, I'll say, remission in quotes. But what would you say?
So I would say 2 things. One is that it's not all doom and gloom. If you spend a lot of time online, unless you're in a particularly good group that is very closely monitored and closely administered, all you hear is either doom and gloom and bad experiences from women, or you'll see other things that may upset you. I don't know, if you want to have a baby and you can't, and you see baby pictures all the time. And that can sometimes be difficult to manage. Therefore, my final word is, it's not all doom and gloom. People do get better, and that's a very common. In fact, that's the rule, not the exception. That if you have the right treatment, and that's not necessarily surgery, but if you have the right treatment, you can get your quality of life back, and that can be long term. And number 2, which is also in the same line, that it's not all doom and gloom, is there are a lot of good doctors around, and it's not that only a very small number of doctors can deal with this. But you need to do your research, and you need to be direct with your doctor and ask them the question, how severe do they think your disease is, and do they have experience and expertise to deal with it? And you'll find that a lot of doctors in this country and all over the world do have that expertise. The number is increasing, the training is getting better, and people are developing interest in endometriosis a lot more than we could say maybe 10 years ago.
Okay. Wow. Thank you so much for this. Honestly, you were right in saying that many of us go on these groups, these support groups, and all you say is, how horrible the disease is, and it just feels like saying there's no cure, saying there's no, this is just like you're just like on a roller coaster of, emotions and like feeling really down. So I'm very happy to be able to, share what this conversation with the audience, with people, and help them know that people like you actually care about your patients, and we should just carry on asking questions, searching for the right person. And I loved what you said about that you can get better, and that's actually the rule, not the exception.
I feel like that's what I'll just put on my on the post saying this. Listen to Dr. Khazali, that this has been really good. So thank you very, very much.
Not at all. Not at all.
I appreciate this.
Okay, Taniela. Lovely.
Bye.
Okay.
Thank you.
Bye-bye.
Bye.
Bye.
I hope you enjoyed this episode as much as I did. If you are in the UK and either suspect or have been diagnosed with endometriosis, you can find the list of endometriosis centers on www.bsge.org.uk/center. Find one close to you and see if you can get referred by your GP. Also, remember that many women have been diagnosed with endometriosis and have been able to go on to live fulfilling lives. So please do not give up hope. Keep learning, keep speaking out, and remember that you are not alone. If you enjoyed this episode, I want to know. Send me comments or even a DM through my Instagram or Facebook page. Share with your friends and subscribe to the podcast. If you also have any questions to ask or topics you would like me to discuss, feel free to shoot me an email on info@notdefinedbyendo.com. I love to hear from you all. All of this information is in the show notes. Until next time, my name is Teniola, and remember, you are not defined by endo.